So we'll be discussing scoliosis and other spinal deformities. So scoliosis is the sideways curvature of the spine. So it could be structural or non-structural. See, structural is permanent, okay? There is a sideways tilt. Along with that, there is a rotation of the vertebrae along the long axis. Whereas non-structural is transient, okay? There is no rotation on the long axis. So non-structural scoliosis, so transient. You can have postural scoliosis, okay? This is mobile or transient. So postural, it is the most common overall type. It is seen in adults and girls. The curve is mild, convex, and usually towards the left, okay? So the main diagnostic feature is that the curve straightens completely when the patient bends forwards. So that is postural scoliosis. Compensatory scoliosis, it is a compensatory phenomenon occurring in order to compensate for the tilt of the pelvis, so especially in hip disease or for a short leg. So the scoliosis disappears when the patient is examined in sitting position in case the leg is short, or when the causative factor is removed. So if you are bending and it disappears, postural. If you are sitting and it disappears, it is compensatory because of pelvic tilt, okay? You're correcting it when you're sitting. Sciatic scoliosis is a result of unilateral painful spasm of the paraspinal muscles, as may occur in a case of prolapsed disc. So structural or permanent scoliosis, so you have different subtypes again. Idiopathic is the most common subtype. So there can be infantile scoliosis, which begins in the first year of life. So it can resolve or it can progress. Then scoliosis beginning later in life, it progresses at a variable rate and usually leads to an ugly deformity. So the deformity is most obvious in thoracic scoliosis because a rib hump is formed. In the lumbar region, even a moderate curve goes unnoticed because it is masked by the compensation, so compensatory curvature of the adjacent part of the spine. Idiopathic curves progress until there is cessation of skeletal growth. Congenital scoliosis, it is always associated with some form of radiologically demonstrable abnormality of the vertebral body. So there can be hemivertebrae, so there is only one half of the vertebrae, okay? The other half is missing. Next, you can have a block vertebrae, that is two vertebral bodies are fused, okay? So you'll have a block vertebrae. And you can have an unsegmented bar, so a bar of bone joining two adjacent vertebrae on one side, thus preventing growth on that side. So these curves will grow often at a fast rate. So congenital scoliosis grows at a fast rate. Next, you can have paralytic scoliosis. Then unbalanced paralysis of the trunk muscles results in paralytic scoliosis of the spine. So polio is the most common cause. Other pathologies like neurofibromatosis also can produce a sharp scoliosis. So pathology, the main pathology is a lateral curvature of the part of the spine. Okay, so this is called a primary curve. The spine above or below the primary curve undergoes compensatory curvature in the opposite direction. That is called a compensatory or secondary curve. The lateral curvature is associated with rotation of the vertebrae. Okay, the lateral curvature, it is associated with rotation. The rotation of the vertebrae leads to prominence of the rib cage on the convex side. Okay, it gives rise to a rib hump. Okay, so that is there. So normal vertebrae, you can see AP view, the spinous process is in the midline, but in rotation it is not in the midline. So any part of the thoracolumbar spine may be affected. Okay, so you can have dorsal scoliosis, dorsolumbar, and lumbar scoliosis. So clinical features, there is a visible deformity in most cases. Pain is occasionally a feature in adults with a long-standing deformity. In exceptional cases, sharp angulation of the spinal cord over the apex of the curve may interfere with cord functions and lead to neurological deficit. So radiological features. So a full AP and lateral view of the spine is necessary, and AP view you need it in supine and in erect positions. Okay. Severity of the curve is assessed by the Cobb's angle. Okay. Cobb's angle is an angle between the line passing through the margins of the vertebrae at the ends of the curve. Okay. So radiological assessment regarding the likelihood of progress of the curve. If you want to see severity, you look at the angle. If you want to see the prognosis, okay, progress of the curve, you look at the iliac apophysis. Okay, so it fuses with the iliac bone at maturity and indicates the completion of growth. So no more possibility of the curve worsening. So this is Reiser's sign. Then rotation of a vertebra can be appreciated by looking at the position of spinous processes and pedicles on AP view. Okay, so normally a spinous process is in the center of the vertebral body. So in case where there is rotation, the spinous process is shifted to one side. Also, there will be asymmetry in the positions of pedicles on two ends. Next, congenital scoliosis, you can find wedging, hemivertebrae, unsegmented bone bar, blocks, etc. Or fused ribs also. In scoliosis associated with neurofibromatosis, you can see erosion of the vertebral bodies. Intervertebral foramina may be widened in a dumbbell-shaped neurofibroma producing scoliosis. So treatment. So you need to assess the prognosis of the curve, and you see and also the deformity it can produce. So you look at the type of the curve, the age at onset, and the site of the curve. So congenital curves progress at variable rates, okay, but they grow faster than idiopathic curves. Neurofibromatotic curves, they progress faster, okay. And the younger the patient, the worse the prognosis. Thoracic curves, they produce a worse deformities because you have rib bulge, okay. So as soon as it is realized that a curve will progress and result in a deformity, the affected part of the spine is fused, okay. So the basic guiding principle is that a straight, stiff spine is better than a curved, flexible spine. Treatment of postural curves is non-operative. It is because of bad posture only. So you train the patient for putting himself in a proper posture, and you also tell him to exercise. So structural curves of less than 30 degrees, well-balanced double curves can also be successfully treated by non-operative methods. For surgical intervention, these are the indications. If there is congenital scoliosis, okay, and radiology suggests fast progression, and curves showing radiological deterioration, okay, and that can result in deformity, you'll operate. And scoliosis associated with backache, you'll operate. For all other curves, the patient is started on a non-op regimen consisting of exercises and a brace. So the progress is monitored clinically and radiologically every 6 months. So non-operative methods, you can have a Milwaukee brace, okay. Next, you can have a Boston brace. It is cosmetically more acceptable. You can have a Reiser sternbuckle cast. Reiser, what we thought of the sign, see, it is iliac apophysis, okay. So you can have a Reiser sternbuckle cast. So it is a body cast with a turnbuckle in between. So tightening the turnbuckle stretches the concave side of the curve and corrects the deformity. Next, localizer cast, okay. So if it stretches the concave side and corrects the deformity. And localizer cast, it is a body cast applied with the spine and traction, okay. So operative methods, you will fuse the spine. So in congenital scoliosis, simple fusion is sufficient. In idiopathic, the spine is fused after achieving some correction by stretching the spine. So you can use traction like cortical traction or localizer cast or halopelvic distraction system pre-operatively, and per-operatively by pedicle screw and rod fixation. Moving on to kyphosis, it is a general term used for excessive backward convexity of the spine, so you bend forwards. So round kyphosis means a gentle backward curvature on the spinal column, so it affects a number of vertebrae, for example senile kyphosis. So because a number of vertebrae are affected, so you will have a round appearance. Whereas angular kyphosis, it means a sharp backward prominence of the spinal column. So it may be a prominence of only one spinous process because of collapse of only one vertebral body, such as in a compression fracture of a vertebra. This is called a knuckle. There may be kyphosis localized to a few vertebrae, which is called a gibbus. It is most commonly seen in tuberculosis, where 2 or more vertebrae are affected. So causes. Diffuse kyphosis, it can be postural. It is the most common type, especially seen in tall individual because they try to stoop forward, okay. So it is corrected by postural training and physiotherapy. Compensatory, so there is an exaggerated lumbar lordosis. The thoracic spine, it develops compensatory kyphosis. Scheuermann's disease, it is a common type. So basically there's a gentle round kyphosis in the lower lumbar spine, okay. It is due to osteochondritis affecting the ring epiphysis of the vertebral bodies. On x-rays, the vertebral bodies appear wedge-shaped, okay. They're wedge-shaped, narrower in the front. In the back, they're okay. Okay, there may be a dull, constant pain during early stages of the disease, but later only kyphosis remains. Conservative treatment is adequate for most patients with pain as the complaint. If the deformity is severe, surgical intervention may be required. Then ankylosing spondylitis. The disease produces a stiff and a kyphotic spine, okay. So it begins in young men as a low backache, which gradually spreads to affect the whole spine. So chest expansion is reduced, and then in a few cases, hips and shoulders are also affected. Spondylolisthesis is the forward displacement of a vertebra over the one below it. So it commonly occurs between L5-S1 and between L4-L5. Occasionally the displacement is backward, so there is retrolisthesis. So normally forward displacement is prevented primarily by engagement of its articular process with the one below it, okay. See, if you look at a vertebra, the inferior articular facet of the vertebra above, it articulates with the superior articular facet of the vertebra below, okay. So this articulation, it prevents spondylolisthesis. So the attachments of the intervertebral disc and the ligaments between the vertebrae also check this displacement, but to a small extent. So any defect in this check mechanism leads to spondylolisthesis. So it can be isthmic. So that is the most common type overall, and the lesion is in the pars interarticularis. So it is the part of the vertebra bridging the superior and inferior articular facets. So three types are subtypes are recognized. So there can be lytic isthmic type. So there is fatigue fracture of the pars interarticularis. It can be intact but elongated pars interarticularis, and there can be an acute fracture of the pars interarticularis. So this allows the separation of the two halves of the vertebra. The anterior half slips forwards over the vertebra below. Anterior half, that is the body, along with the superior articular facet and the pedicles, along with the whole of the spinal column above it. It slips forwards. The posterior half remains in contact with the lower vertebra. So you can have isthmic, pars interarticularis, either fatigue fracture or elongation or acute fracture. Okay. Then dysplastic, it is the least common type. There's a congenital abnormality in the development of the vertebra, so one vertebra slips over the other. It can be degenerative. So it is seen in elderly people. The posterior facet joints become unstable because of osteoarthritis in the subluxate. So it is occasionally backwards rather than forwards. So retrolisthesis. Pathological. It results from a generalized or localized bone disease weakening the articulation between the vertebrae and traumatic. Okay, so it is very rare. Diagnosis. So clinical features, again, the isthmic type presents in adolescents and in young adults. The degenerative type occurs in old age. So symptom is usually backache with or without sciatica. The symptoms become worse on standing and walking, and sometimes there may be neurological deficit in the lower limbs. So in a number of cases, the abnormality is symptomless and is detected on routine X-ray taken during screening for a health checkup. On examination, there is often a visible or palpable step above the sacral crest due to the forward displacement of the spinal column. There may be increased lumbar lordosis. There may be evidence of stretching of the sciatic nerve as found by the SLRT test. X-ray examination, so you can see anterior displacement of one vertebra over the other on lateral view of the spine. So grade 1 spondylolisthesis means vertebral displacement is up to 25% of the AP width of the lower vertebral body. See, if this is a sideways view, lateral X-ray, then this will be the AP diameter, okay? So grade 1 spondylolisthesis is displacement up to 25%. Okay, so up to 25% it is forward displacement. Whereas grade 4 means complete forward displacement of the vertebra. So in an oblique view of the spine, you can show a defect in the pars interarticularis. So in a normal vertebra, the pars interarticularis looks like a Scottish dog. Okay, so if you are looking at a Scottish dog view on oblique view of the spine, you are seeing the pars interarticularis. If the appearance is like that of a Scottish dog wearing a collar, the defect is in the isthmus, pars interarticularis, and the patient has a spondylolysis. Okay, it is a defect without slipping of the vertebra. If the head of the Scottish dog is separated from the neck, the patient has a spondylolisthesis. It is a defect with the slip of the vertebra. So treatment. Principles of treatment for a mild symptomless spondylolisthesis, no treatment. If the symptoms are mild, conservative methods like brace and spinal exercises. If the symptoms are moderately severe or severe, especially if they hamper the activity, so operation may be required. So methods, again, conservative methods, rest and external support followed by flexion exercises. The patient is advised to change his job to a physically less demanding one. Operative methods, you can do decompression of any compressed nerves followed by fusion of affected segments of the spine. So it is commonly achieved by fusion between the transverse process of adjacent vertebrae. So inter-transverse fusion. Use of internal fixation devices like pedicular screws and rods has helped in early mobilization of the patient.